Thinking about an atrial fibrillation ablation, don't just assume all doctors do it the same way, because they don't. In fact, whether your ablation works or fails can depend entirely on the electrophysiologist that you choose. In this video, I'll show you exactly what to ask your doctor before scheduling your ablation, so you don't get stuck with a cookie-cutter procedure that doesn't treat your atrial fibrillation. Some EPs do 3 to 6 ablations a day. That sounds impressive until you realize they're doing the same basic procedure on everyone. Just a quick one-wall pulmonary vein isolation, in and out. But if you have a more advanced stage like persistent or long-standing persistent atrial fibrillation, that approach isn't enough. Your AFib is coming from more than just the back wall pulmonary vein. You may have non-pulmonary vein triggers, which are areas on the posterior wall or circuits that need detailed mapping and targeting. Other walls that are considered non-pulmonary vein triggers would be the posterior wall, the left atrial appendage, the floor, which is the structure called the coronary sinus, the anterior wall, and even the right atrial appendage. If your EP isn't looking for those other non-pulmonary vein triggers and you have a later stage of AFib, your procedure is already set up to fail. So what questions should you ask? Well, how many AFib ablations do you perform per year? It's true, high volume EPs tend to get better results, but only if they're doing quality work. Do you routinely treat persistent or long-standing persistent atrial fibrillation, the later stages? Some EPs only do early stage paroxysmal cases. If your AFib has progressed, then you need somebody more experienced in complex ablations. Because if you go to somebody who only does one-wall pulmonary vein isolation on everybody, regardless of the stage, that would be like taking an 80% forest fire, getting rid of 10 or 20% of it, and leaving the other 60%. Another question, do you target non-pulmonary vein triggers, such as we said, the posterior wall, the left atrial appendage, the coronary sinus is on the floor, anterior wall, or right atrial appendage? If they say they just do pulmonary vein isolation for everyone, regardless of the stage, and then walk away, unless, of course, you actually have a very early stage of AFib, where just doing that first one would be enough. Another question, do you stop my antiarrhythmic drug before the ablation? Why does that matter? Because stopping your antiarrhythmic medications beforehand can allow an electrophysiologist to wake up your atrial fibrillation triggers and get them known so you can map them. That way, they can be identified and ablated. If your EP doesn't stop your antiarrhythmic medications that are actually suppressing your AFib, they might be suppressing the real problem during the procedure and not be able to see what they need to do. Now, some electrophysiologists just do things anatomically, where they say, I'm just going to do that first wall or 2 walls and shock the rest back to sleep. But see, that's where they're more likely not to get you the result that you need, especially in these advanced stages. Another question, do you plan to stop my antiarrhythmic drugs after the 3-month blanking period? See, there's a 3-month blanking period where after the procedure, you have to let cells die off and things settle down. So we don't say the long-term results until after we give it about 3 months after the ablation. But are they planning on keeping you on the drug, the antiarrhythmic drug that's suppressing your AFib, after that 3-month period to just keep whatever AFib they didn't get rid of asleep, or are they planning to stop it to really see did they get rid of everything or not? If they keep you on the drug long-term, it could be masking the remaining atrial fibrillation that they didn't ablate. That's not success, that's suppression. Another question, what's your success rates? And is that broken down by atrial fibrillation stage? If they just say 70% for everyone, regardless of the stage, that's a red flag. Success rates vary greatly depending on the stage of your atrial fibrillation. You want someone who knows their numbers for cases like yours. Another question, how often do you need to do a second ablation? Some patients do need a touch-up, but if they're doing lots of redos, that may mean that the first one wasn't comprehensive enough. Another question, what energy source do you use? Do you use radiofrequency, cryoablation, or pulse-filled ablation? Each energy source has its pros and cons, but remember, the main determinant of AFib success rate is not the energy source used. It's number 1, the stage of AFib, the stage of AFib progression. How big is your forest fire? How many of these AFib cells do you have on more walls? Obviously, the bigger your forest fire, the more walls you have AFib cells on, the harder it is to get rid of it. And number two, the skill of the operator doing your procedure. Are they prepared to match the lesion set and do a complex lesion set to match what you have stage of forest fire? Or are they just doing a one wall 10 or 15% forest fire ablation on everyone regardless? Make sure your EP isn't choosing what to do on you based on speed, but what's right for your case. Do you routinely ablate patients' atrial fibrillation into sinus rhythm? Or do you just do the pulmonary vein isolation ablation and then shock any remaining atrial fibrillation back to sleep and plan for additional procedures if those areas wake up later? The truth is, ablation for AFib is not a one-size-fits-all. If your EP is just doing a quick one-wall pulmonary vein isolation on everyone, you could walk away with suppressed but not eliminated AFib. Or worse, end up right back where you started. But if your doctor takes the time to identify your exact AFib stage, look for non-pulmonary vein triggers, strategically stop and restart your medicines, and tailor your ablation to your heart, then you've got a real shot at durable success. So before you schedule that ablation, ask these questions. Write them down. Take them to your appointment. And if your doctor can't or won't answer them, it might be time to get a second opinion. If you found this video helpful, please like us, share, or subscribe for more videos that help you take control of your AFib care. Your heart deserves better.
Fibrillation related, please feel free to go to my website, drscottlee.com, where you're going to find more resources and also can follow me on social media.